Dr. Madhu Choudhary, your pathology faculty at DigiNerve. Today we'll be discussing some potential MCQs that could be asked in your upcoming INI-CET exams. I'll be discussing pathology and micro questions. So let's begin. First question. Which pattern of ductal carcinoma in situ is shown in the following figure? See, it's a very simple question. We all know what patterns are seen in ductal carcinoma in situ. We all know these are solid, comedo, papillary or cribriform. And the image given in our question, very simple. The correct answer is comedo pattern, right? Moving on to the next question. Gleason's classification is used for which of the following carcinoma? Again, a very simple question. Gleason's classification, we all know it is used for prostate carcinoma. So the correct answer is option A, that is your CA prostate. Now, which of classifications are used for breast, pancreas and rectum? Carcinoma breast, we use the Bloom-Richardson or Nottingham grading system. Pancreas, we all know it is WHO or AJCC. And CA rectum also, we all know it is either modified Dukes, Astor Collar or TNM classification. CA rectum, we all know it is modified Dukes, Astor Collar or TNM classification, right? Let's move on to the next question. A 60-year-old vegetarian man presents with symptoms of fatigue and weakness lasting several months. Physical examination reveals pallor. Laboratory results show hemoglobin of 9 and an elevated MCV of 110. Now they have asked you what is the most likely diagnosis. See, in such questions I have always told you, go through the question thoroughly. It will just take 1 minute extra to go through the question thoroughly. What are the features that you have to understand? What are the features that you have to note? He's a vegetarian man. Signs and symptoms of anemia, which is very well confirmed with your hemoglobin, that is your 9, and an elevated MCV. Once you see it is an elevated MCV, your thalassemia and iron deficiency anemia have been ruled out. So we are now left with two options. It could be either aplastic anemia or megaloblastic anemia. See, 60 years aplastic anemia is also possible. But what is the most important feature here that will tell you the answer? It is a vegetarian man. Vegetarian man means it has to be megaloblastic anemia unless and until aplastic anemia ruled out, right? 60-year-old man में aplastic anemia हो सकता है. But they have asked you the most likely diagnosis, it is megaloblastic anemia here, right? So the correct option here is megaloblastic anemia. Please note, aplastic anemia may be, MCV could be normal or slightly elevated, but the word vegetarian will definitely give you the answer of megaloblastic anemia, right? So moving on to the next question. A 58-year-old female presents with severe left-sided chest pain radiating to the left arm and jaw for the past 40 minutes. Cardiac enzymes are elevated, she started on thrombolytic therapy, 5th day of the treatment, she collapses and dies. Such a complicated question, right? But what have they asked? Please read the question thoroughly. I know first sight it sounds very complicated, but what have they asked you? Autopsy reveals necrosis. What type of necrosis it is most likely present? See, such a complicated question, but a very simple answer. What is the most likely necrosis that you see in the heart? Very simple. The necrosis that you see in the heart is option B, that is your coagulative necrosis. Now, where do you see liquefactive necrosis? Liquefactive necrosis is usually seen in brain. Caseous necrosis, tuberculosis. Fibrinoid necrosis, immune-mediated vasculitis. So, a complicated question with a straightforward answer. Necrosis in heart is your coagulative necrosis, right? Moving on to the next question. A 35-year-old woman presents with a painless, firm, moderate goitrous enlargement of the thyroid. Lab results show serum T3 and T4 reduced. Radioactive iodine uptake is also reduced, that is 3% and 24 hours. Microscopy shows the images given below. Which of the following is the most likely diagnosis? See, what do you see in the biopsy? You see sheets of lymphocytes. even if you were not given the biopsy, you know it is not Graves' disease. Why? Graves' disease mein you will see hyperthyroidism, but here our patient has hypothyroidism. Even the radioactive iodine uptake is low. Subacute thyroiditis, again it is not subacute thyroiditis. Can anybody tell me why is it not subacute thyroiditis? Because it is a painless form. Subacute mein you will get a painful swelling. And why is it not a thyroid lymphoma? See, thyroid lymphoma mein you will see, first of all, 35 years old, thyroid lymphoma, unlikely, and moderate goitrous enlargement, and moreover you are not seeing atypical lymphocyte or any mitotic figures. So our answer is Hashimoto's thyroiditis, where you see hypothyroidism, reduced radioactive iodine uptake, and sheets of lymphocyte. So the correct option is C, right? Moving on to the next question. A 50-year-old man presents with pruritus followed by tense bulla on the trunk, legs and arm. Biopsy with direct immunofluorescence shows subepidermal bulla with linear immunoglobulin G and C3 deposits at the dermal epidermal junction, right? So we have a 50-year-old man, pruritus, tense bulla. Please remember tense bulla, and direct immunofluorescence showing subepidermal bulla with linear IgG and C3 deposit where? At the dermal epidermal junction. The lesions heal without scarring after the steroid treatment. Now they have asked us which skin component is the target of autoantibodies. For this question we need to first arrive at the diagnosis, then only we can tell them which is the target of the antibodies, autoantibodies, right? So what is the diagnosis? Please remember tense bulla and linear IgG and C3 deposit at dermal epidermal junction. So the diagnosis is bullous pemphigoid. This is a very beautiful table comparing the features of pemphigus and bullous pemphigoid. Important features to remember is pemphigus mein you will see soft blisters, bullous pemphigoid, the case here you will see tense blisters. That is what it is there in our question. And important differentiation feature is in the direct immunofluorescence you will see a fishnet pattern in the epidermis. For IgG in the epidermis, a fishnet pattern, whereas in bullous pemphigoid you will see linear positivity for IgG and C3 along the dermo-epidermal junction. That is the case given here. So what is the pathogenesis? The autoantibodies are seen against the hemidesmosomes in our case, right? And in pemphigus it is against the desmosome. So coming back to the question, the skin component which is the target for our autoantibodies here is hemidesmosomes. Understood? The case is bullous pemphigoid, right? Let's move on to the next question. A 40-year-old man presents with a slowly enlarging pearly nodule on his right upper eyelid, lateral limbus for the past 2 years. Excision histology shows pigmented cell, keratotic masses, cystic changes with sebaceous differentiation and adenoid pattern with apocrine or ecrine differentiation. Now what is the most likely diagnosis? Any guesses? See, they have told you all the important characteristic features of, yes, basal cell carcinoma. You can see pearly nodules, characteristic histology, pigmented cell, keratotic masses, cystic changes with sebaceous differentiation and adenoid pattern with apocrine or ecrine differentiation. Characteristic, everything has been mentioned in all your standard textbook, the characteristic histopathology of basal cell carcinoma, right? So the answer is basal cell carcinoma. Looking at the other option, why is it not actinic keratosis? You will see atypical keratinocytes in that, which is not present here. Dermatofibroma, again no spindle cells seen. Malignant melanoma, no atypical melanocytes invading the dermis, right? So characteristically it is basal cell carcinoma, right? Moving on to the next question. An elderly male with history of smoking presents with chronic cough and significant weight loss fatigue. Lab investigation shows serum calcium of 12.5, Biopsy of the lung lesion shows the presence of keratinization and intercellular bridges. IHC is positive for P63 and cytokeratin 5/6. What is the most likely diagnosis? I don't know why have they given a serum calcium level. Could be to confuse you, but again they have given keratinization and intercellular bridges and diagnostic IHC P63 and CK56 positive. So what is the most likely diagnosis? Yes, it is squamous cell carcinoma. Let's see why have we ruled out the other options. See, adenocarcinoma, we know it is the most common lung cancer after lung metastasis, right? Then it is also found in non-smokers, the location is peripheral, and the pathogenesis there is EGFR, ALK mutation and KRAS mutation. Adenocarcinoma where you will see TTF1, MUC1 and NSI and AO positivity. Squamous cell carcinoma, our case here, seen in males, smokers, central location, P53 mutation and characteristic IHC that is P63 and P40 positivity. Small cell cancer, we all know it's a neuroendocrine tumor, central location, P53 and RB gene mutation along with LMIC amplification. Also, all the markers for neuroendocrine tumors will be positive in your small cell cancer. So, the correct answer here is squamous cell cancer showing P63, CK56 and P40 mutation, right? Let's move on to the next question. A 25-year-old male presents with a history of recurrent spontaneous pneumothorax, easy bruising, thin translucent skin with visible underlying veins. He also reports a family history of sudden death of his father due to aortic rupture. Genetic testing reveals a mutation in COL3A1 gene. Thankfully, they are not asking you to diagnose the case. They have already told you it's a COL3A1 gene mutation, so it is Ehlers-Danlos syndrome. Now, they are asking you which type of Ehlers-Danlos mutation, right? Before answering, I would like you to go through this table, right? COL3A1 is your type 4 Ehlers-Danlos or the vascular. Other mutations have already been listed in this table. You just need to mug it up. COL3A1, more commonly it is vascular. They can also ask you for COL5A1, that is your classical, right? So, the correct answer here is vascular type 4, right? So, the option C is the correct answer. Moving on to the next question. According to the modified Duke's criteria, which of the following is classified as a major criteria for infective endocarditis, right? Now, I hope all of you know what is the modified Duke criteria for infective endocarditis. So, isolation of Coxiella but from at least more than 2 separate blood samples? No, only one sample is necessary. Isolation of typical organism in more than 2 culture samples? Yes, this is the correct answer. So, major criteria says isolation of typical organism in more than 2 culture samples. Presence of oscillor nodes, Roth spots, history of previous valve repair fall under the minor criteria. Major criteria is option B only, right? So, this is the modified Duke's criteria for infective endocarditis. So, the answer here is typical organism in more than 2 separate blood culture. What could be the organisms? It could be viridin streptococci, streptococcus gallicus, hack organism, staph aureus or community acquired enterococcus, right? More than 2 samples of blood culture. And now this is the minor criteria where your oscillor nodes, Roth spot and previous valve repair come into picture. Alright, let's move on to the next question. A 7-year-old child presents with painless rectal bleeding and prolapsing rectal mass. Colonoscopy reveals multiple colonic polyps. Now, histopathology is given below. Which of the following is not associated with this condition? Right. Given the history and the image given below, what do you think is the diagnosis? It is 7-year-old painless rectal bleeding and prolapsing rectal mass. So, the most probable diagnosis in this 7-year-old child would be juvenile polyposis syndrome, right? Now, which of the following is not associated? It is hereditary hemorrhagic telangiectasia? Yes, it is. Hematomatous polyps in the stomach and small intestine? Yes, indeed it is also true. And germline SMA D4 mutation is also true. Please note, it is not an X-linked recessive inheritance. It is, yes, it is an autosomal dominant inheritance. So option D is the correct answer here. Coming to the next question. Finding of nephrotic range protein urea and elevated serum creatinine seen in a 64-year-old female with long-standing history of uncontrolled type 2 diabetes mellitus. Renal biopsy is given below. Which of the following is the most characteristic finding? Right. Most characteristic finding, you can also identify what is given in the renal biopsy. It is your KW nodules or Kimmelston-Wilson nodules. That is your nodular glomerulosclerosis. So the correct answer here is nodular glomerulosclerosis, right? It's a case of chronic diabetic nephropathy. So the correct answer is option B. Why is it not Ermani-Ebsten lesions? See, these kind of lesions are not seen in chronic cases. You can see it in acute stages. And amyloidosis, of course, amyloidosis, this picture is entirely different. Amyloidosis, you will use a Congo red stain, okay, birefringent apple green. Focal segmental glomerulosclerosis, again this is the incorrect option. So the correct option here is nodular glomerulosclerosis. Moving on to the next question. Which anticoagulant is used in test tubes for HbA1c estimation? Now you use HbA1c estimation for? Yes, to see the, now for what HbA1c estimation is used for? For diabetes, right? The long-term control of diabetes. But please note, this HbA1c has nothing to do with the glucose estimation. Okay, HbA1c, whenever Hb comes, what is the anticoagulant? Whenever Hb or hemoglobin comes, the anticoagulant is your EDTA. Please don't mark sodium fluoride considering glucose hai to sodium fluoride hoga. Nahi. Whenever Hb comes, hemoglobin comes, your anticoagulant would be EDTA. Okay, just let's quickly revise the color codings of all the vacutainers. Red vacutainer, the anticoagulant, there's a clot activator only and you use it for serum biochemistry and serology. Blue, sodium citrate in a ratio of 1:9. Please note the ratio is 1:9 and is used for coagulation studies. Purple, we all know purple or lavender, it is EDTA. All for your hematology test and the HbA1c as asked in this question, it is your lavender tube, that is EDTA. Heparin, green, used for plasma chemistry and blood gases. Grey is sodium fluoride plus potassium oxalate used for glucose. Okay, glucose के लिए you will use a grey vacutainer, HbA1c के लिए use a lavender vacutainer. Now, light pink is again EDTA but for all your blood bank typing tests, right? Orange के लिए it is again a clot activator plus gel, all your hormonals, enzymes and lipids. Yellow is ACD or SPS for blood culture and HLA typing. Black is again sodium citrate, but the ratio here is different. For coagulation studies, the blue vacutainer we used 1:9 ratio, in black we use 1:4 ratio and it is used for ESR, right? Come, next question. A 40-year-old patient presents with seizures and focal neurological deficits. Imaging studies reveal a well-circumscribed tumor located at the cerebral hemisphere. The histopathology is given. What is the most probable diagnosis? Again, histopathology characteristically shows which feature? Very important, very commonly asked. This has been asked n number of times. The histopathology shows a fried egg appearance. You see fried egg appearance, the cells with a perinuclear halo. So the answer here is oligodendroglioma, right? The answer here is oligodendroglioma. It is not an astrocytoma, no reactive astrocytes, not a meningioma. What is the characteristic feature that you see in meningioma? You see whorled patterns and you see psammoma bodies. Glioblastoma multiforme, again, no palisading, no necrosis. So the correct answer here is oligodendroglioma. Understood? Let's move on to the next question. Now, based on the provided peripheral blood smear, which of the following is the most characteristic of sickle cell anemia? Right, they've told you it's a case of sickle cell anemia. We can see sickling of the cells also. What is the most characteristic inclusion body that you see in sickle cell anemia? These are your, yes, these are your Howell-Jolly bodies seen in sickle cell anemia. What are Howell-Jolly bodies? These are single dot nuclear remnant. Remember, single body, nuclear remnants. Now, Heinz bodies are also single bodies. Okay. What is the difference between Heinz body and Howell-Jolly bodies? Both of them are single dot inclusions. However, Howell-Jolly bodies are nuclear remnants and Heinz bodies are denatured globin chains. Where do you see Heinz bodies? Heinz bodies are seen in G6PD deficiency. Also, please note that Heinz bodies can be seen in, yes, they can be seen only in supravital stains. Whereas in Romanowsky stains, what will you see in G6PD deficiency? You will see bite cells. Okay, you will see bite cells in Romanowsky stains for Heinz bodies. Pappenheimer bodies, what are Pappenheimer bodies? These are multiple inclusions and these are iron granules seen in, yes, they are seen in sideroblastic anemia. And again, Dole bodies are seen on neutrophils, right? The first three are the red cell inclusions. Dole bodies is associated with neutrophils. So the correct answer here is Howell-Jolly bodies. Understood? Let's move on to the next question. Which of the following coagulation factors is complexed with von Willebrand factor? Okay, this is a very simple question. Von Willebrand factor is associated with, yes, it is associated with factor 8. What is the function of von Willebrand factor? Can anybody tell me? See, von Willebrand factor will combine with GP1B9 and will cause platelet adhesion. Von Willebrand factor also associates with factor 8 and does what? It stabilizes and prolongs the half-life of factor 8, right? So the correct option here is factor 8. Also, please note that von Willebrand factor is a multimeric structure. It has to be reduced in smaller forms and it is done by the help of your ADAM TS13 enzyme. Please note, we have already studied this. Deficiency of this enzyme causes, yes, deficiency of this enzyme causes TTP, right? So let's move on to the microbiology questions now. Pathology over microbiology questions. Which of the following statements is true regarding trematodes? So let's see every option. Fascicola hepatica are seen in the intrahepatic biliary radicals. True or wrong? Yes, it is true. So the correct answer is A. Schistosoma are monoecious. No, they are dioecious. Fascicola hepatica are acquired through contaminated water. No, they are not acquired through contaminated water only, through contaminated vegetation, right? Triclabendazole is the treatment of choice for all trematodes infection. No, it is the treatment of choice of Fascicola hepatica only. For the rest, we can also use praziquantel. So the correct option is they are seen in intrahepatic biliary radicals, right? Coming to the next question. A 55-year-old male had a tooth extraction 3 days back. He now presents with a mass in the submandibular region and is otherwise asymptomatic. No oral ulcer. On drainage, the discharge is foul smelling with a lot of yellow granules, show gram-positive filamentous rods on gram staining, right? Please note, the discharge shows foul smelling yellow granules. Yellow granules should raise the option. Yellow granules should give you the correct answer. Again, it is gram-positive filamentous rods, gram staining. So your answer is actinomycosis. Direct question, yellow granules, you should know it is actinomycosis. Next question. A truck driver presents with a painless hardened genital ulcer following unsafe sexual contact. Which of the following methods can be used to diagnose this condition in a low resource setting when an active ulcer is present? See, the history itself gives you an idea of the diagnosis. It could be primary syphilis, truck driver, painless, hardened genital ulcer and unsafe sexual contact and active ulcer is present. Syphilis ke liye the low resource setting, what is the first step in the diagnosis is what is the first step for investigation? It is your dark field microscopy, right? Very simple. Next question, identify the virus given below. Again, a very simple question. You can see an enveloped virus having an outer envelope, middle matrix and an inner core. So, it is your HIV, right? Very simple. So, I would like to end this session by saying that solving the MCQ is an art. So, keep on practicing. First round of revision, second round of revisions, you should always start practicing MCQs, solving MCQs, giving mock test, giving grand test. MCQ solving is definitely an art and you can achieve excellence only with practice. So, keep practicing MCQs, keep solving them and strive to excellence. Thank you.